One thing that I learned this week is that the forces on the hip are absolutely incredible. It provides this important linkage, obviously, between the trunk and lower extremity, but the center of gravity of the whole body is anterior to S2. And so that center of the pelvis receives much of the force. And if you look at the large forces acting on the hip, when you do just slow walking, it's 300% of your body weight, okay? Now move that up to quick walking, it goes up to almost 400%, 4 times your body weight on the hip itself. Jogging to 500, and if you stumble and suddenly axially load that, it goes up to 8 times your body weight. That's pretty phenomenal that our hips aren't all just completely degenerated by the age of 30. But if we look at this, there are a lot of imaging challenges because of the complex three-dimensional anatomy, and we know on radiographs we can miss, trucks within the pelvis. And there are also clinical challenges because it's an area of common injury, but there are multiple sites in close proximity and also distant things that can refer pain to the hip. So what we're going to do is look briefly at the normal anatomy and then look at the various types of injury sites that can refer pain to the hip. Now, in terms of technique, again, remember we want to use a phased array pelvic coil if possible. And then we want to move down to a phased array surface coil if we're going to be doing arthrography or some high-res 3T kind of work. Our standard pelvis, we do coronal T1 stir and then axial of these and a sagittal. Now, this was a young, about 22-year-old runner who had low back pain, and she turned out to have a sacral stress fracture. Athletic pubalgia has been a big, common, very hot topic for the last few years, and a way to scan for that, because we're really focusing on this area of the symphysis pubis right here, where the rectus femoris comes down and forms the rectus kind of adductor aponeurosis. So we really want to cut perpendicular to that. Some of the articles have recommended going on the pelvic brim on one of your sagittal scans and going in that plane. I like to just go relatively perpendicular to the symphysis from a sagittal localizer, and then doing some of these specific scans that we don't typically do with our routine pelvis. They also recommend, and I would agree, with using a surface coil on the anterior part of the pelvis to really highlight that area of the symphysis. And here you can see the symphysis with that rectus aponeurosis, which is so important for stabilizing that region. Contrast we use for infection. This was a child with a septic right hip. We also use it in the pediatric hip when we're trying to sort out whether there's infection or some other cause, because we've had a couple of cases like this, absolutely normal except for a small effusion on the right. When we gave contrast, you'll notice the lack of enhancement in that right capital femoral epiphysis. Now, we at the time, and there were some case reports in the literature saying, oh, well, this is early Legg-Perthes disease. It's ischemic and causing the hip pain. But there have also been at least 1 or 2 articles saying that early infection, you may also see decreased blood flow. So you're not quite out of the woods there. It's enough that we would probably need to tap the hip on a patient like this. But I will tell you that the T1 and T2 can be very misleading in children, so we typically will use gadolinium with them. And then certainly, as Mark Kransdorf was talking about, for cystic appearing masses, we want to confirm they're truly cysts. Arthrography, we use the same dilute gadolinium technique and do a lot of T1 with and without fat sat. You want to be sure, as Dr. Resnick mentioned this morning, to do at least 1 T2, and we usually do more than 1, to look for periarticular cysts or cystic masses that may not fill with gadolinium and become apparent on a T1 weighted image. We're all familiar with the acetabulum that forms at the triradiate cartilage from the iliac pubis and ischium. As we look at the acetabulum, it's an upside-down U pointed slightly forward that has an acetabular notch. It's like a horseshoe. It's incomplete down here. And then an acetabular fossa centrally, which is nicely shown in the cadaver with this fat around the kind of transected ligamentum teres. And you can see the articular, the white articular cartilage in this almost ball and socket joint. Now, here you see the labrum, which is a gasket going around the edge of the acetabulum, and you'll notice also across the acetabular notch, where the bone is incomplete, we have the transverse acetabular ligament. One of the papers I was reading about the hip stability was talking about the fact that the labrum actually has almost like a suction cup effect on the joint and keeps a certain amount of negative pressure around the femoral head, such that they were able to resect almost everything, and the femoral head still stayed within the acetabulum based just on that kind of negative pressure. So it does have an important function, it seems like, for improving the congruity of this joint. Now, if you look, you'll notice the fibrocartilaginous labrum here and the hyaline articular cartilage here. Notice that there is no cartilage, there shouldn't be, as we get into the acetabular fossa here. So here again, we see the articular cartilage up here, the dark triangular labrum here with the contrast outlining it. Here's the transverse acetabular ligament cut in cross-section, and here you have the ligamentum teres. Now there are some normal variants. One is the perilabral sulcus, where you just see fluid going up on the outside of the labrum. They've also described, and this has been very controversial, but some sublabral sulci that are supposed to occur in the lower part of the labrum at the 4 and 8 o'clock positions. And so this was a case where when we look at this, you can see in the lower part of the acetabulum these little sulci, anterior and posterior. I find this really difficult because I find the labrum really difficult. But just understand that some people believe there are some sulci, if you're below the equator, both anteriorly and posteriorly, it can be normal. Ligaments of the hip, we have these iliofemoral ligaments called the inverted Y ligament there. We have the pubofemoral ligament here that resists abduction of the hip. And then here you can see on MR, these are really primarily like thickenings of the capsule, but they have an important stabilizing effect in these various ranges of motion. Posteriorly, Netter shows the ischiofemoral coming from the ischium, which helps to resist flexion or becomes tight with flexion along the posterior aspect of the joint. So I don't usually see injuries to these. I don't usually comment on the actual ligaments, but just know that that's what they are. Now the ligamentum teres I will take a look at because you can see pathology there. You remember that enters the fovea of the femoral head, and here you see it in cross-section. Notice again beautifully the articular cartilage and the acetabular fossa here with the ligamentum teres. Now, many tendinous attachments around here. If we look at the anterior superior spine, we see the sartorius and tensor fascia lata take off there, the rectus femoris anterior inferior spine. The ischial tuberosity, big, broad attachment of the hamstring, common hamstring tendon. Here we have the all-important rectus abdominis, as we're going to talk about with athletic pubalgia, and then here the important adductors that go from the symphysis down along the inferior ramus. Here you can see the anterior inferior iliac spine here with the rectus femoris coming off in the coronal. Here it is in the sagittal plane. Notice the iliofemoral ligament lying just deep to it next to the joint. As we look on a parasagittal scan, you can see the big hamstring tendon coming off of the ischial tuberosity. Kind of a no man's land for me for many years, but really started looking here when there were some articles coming out about pathology of the gluteus medius and minimus. And we see this a lot in older patients as a cause for hip pain. So here we see the gluteus medius coming in more posteriorly on the greater trochanter. As we move more anteriorly, we see the gluteus minimus. And some people have called this the rotator cuff of the hip because it's like this continuous fascia between these two tendons, but an important area to look for lateral hip pain. Now, in terms of vessels and nerves, we don't see these directly, but we can see the effects if there's trauma, AVN, etc. We have the medial circumflex femoral vessels. You remember that these go in an ascending pattern to usually serve most of the head with a very small amount coming through the artery of the ligamentum teres. The three nerves are going to be the femoral nerve, shown here, the obturator nerve, which I don't usually look at, and then the sciatic nerve running right next to the common hamstring tendon coming off the ischium. I always love to just kind of stop and take a nice deep breath looking at this because it takes my breath away just to see the sciatic nerve in the continuity coming down, again, right next to the common hamstring, right along the ischium. Now let's talk about pathology. There are a lot of sources of pain. So we're going to talk primarily about stress injuries, a little bit about avulsions when we talk about tendons. We're going to look at labral and chondral pathology, some tendon, primarily avulsion injuries, and then finally, things that can refer pain to the hip from the lumbosacral spine. Now, you remember stress fractures can be of a fatigue or insufficiency, depending on whether the bone is normal or abnormal, but they all look alike. And I used to try and figure out, is this a stress or fatigue or insufficiency fracture? I personally tend to say, is this in cortical bone or trabecular bone? Because they look very different, and that's what I want to emphasize. If we look at Netter's diagram of cortical bone, as you increase activity, you begin to develop little microfractures within the cortex. It happens to all of us every day. It's just subclinical. You don't even notice it, but this is probably how Wolff's law works with remodeling of the bone according to stresses, because as you develop these microfractures, which they can show histopathologically, the osteoclasts will come in and start resorbing them for the osteoblasts to come lay down some new bone in response to that stress. Well, there's a couple of week window there between the resorption and the formation, and at that point, the cortex is weakened. All right, so now most people, if they become symptomatic of that region, are going to stop and say, oh, that kind of hurts. But obviously, your high-level athletes will try to play through the pain, or type A, 50-year-olds will try to do the same thing. And then, as that begins to accumulate, the cortex may fail and develop a true stress fracture. So, this is the pathophysiologic kind of continuum here. What happens on the radiograph? Well, it sits normally until way down here. A lot of studies show that it's very, very poor sensitivity, even as low as 15% when the patient presents with pain in the emergency room, so that it's not uncommon at all to see a normal radiograph. The earliest finding is probably going to be the gray cortex that I'll illustrate. This is where we'll often pick it up because we'll notice the periosteal buttressing. Because of that temporarily weakened cortex, the periosteum gets active and starts laying down some new bone here. You may see the same thing along the endosteal surface. Then finally, we may see a fracture line. But let's talk about the gray cortex. Well, the only reason I know it's there is because we saw this 4 weeks later, and we saw this kind of mature-looking periosteal new bone formation here, and we went back and said, gosh, can we see it? If you look at the cortex on this side, look how sharply defined it is. And there, I know you think I'm crazy, but it actually does kind of work sometimes. And so if you see this subtle graying where it's very sharp here, and then all of a sudden it's gone, and when I'm looking on a PACS monitor, I tend to blow these up because I know metatarsals are a common area and so on, and just kind of look at them on a mag view just to see if there's any gray cortex. All right, well, let me show you another one. This one we called normal, and this was a 30-year-old lady with left hip pain. Called this normal. She got an MR. Not normal. So she's developing a stress reaction, maybe early fracture over here. So then again, we went back and looked and said, can we learn something from this? Well, look at the normal cortex on this side, and now do you see the gray cortex here? These things are real, and you're actually seeing the osteoclastic tunneling, and you can see it very nicely with CT, that's been reported. But occasionally on plain films, you'll be able to pick up this very early finding of a developing stress fracture. Now, they look completely different in trabecular bones. So if you're dealing with a vertebra, calcaneus, and so on, then we're going to be seeing what are these microtrabecular fractures, which we have no hope of seeing because there's so little calcium in that region of the bone. However, we'll start to pick these up as it begins to form microcallus along these. And so the finding on the radiograph is typically a sclerotic band. It doesn't look anything like the cortical stress fractures. And by the time we see this, there's usually a fair amount of callus down, so it's actually tends to be on the healing side. But again, if we know what to look for, we might see it earlier. Now on MR, if we look at the spectrum here, we're going to see marrow edema typically early, and then we may see also some periosteal changes, and then finally the same fracture line. But marrow edema is going to be the big one we look for. So here again is, I believe this is that same young runner where we have, 23-year-old long-distance runner, and she had low back pain. You see the T1 abnormality related to the edema. Now here, if you look, we see maybe a little fracture line. Now clearly on T2, she's developing a fracture line. So how do we diagnose these? Because sometimes you don't see the fracture line. And in a young athlete, it's a lot easier than in a 70-year-old, and you're trying to decide, is this an insufficiency fracture or not? Well, clinical information, location, and morphology, all right? And the location in the pelvis is so classic. If you see some change, especially in both sacral ala, as you know, that's going to be a stress reaction until proven otherwise. Now, the other areas are a little less common, but if we look here, this is one of my good friends who said, I got a little bit of hip pain. He came in, and you can see some abnormal T1 signal in his left supraacetabular region. Look what this guy was running around. I mean, this guy was doing miles every week and saying, I've got a little bit of hip pain. So he took some time off. But here you can see a supraacetabular fracture. Perisymphyseal, and we'll talk about athletic pubalgia, but that's a very common area to develop stress changes, and so we'll see edema there quite frequently. Now, if we look in the morphology, all right, we're looking for linear abnormality. Now, sometimes, as I said, we can't see it. And if it happens to be maybe an athlete that's a little bit older, not sure whether it's stress or not, then we might be dealing with a tumor, metastasis, something else. And if I can't see a fracture line and it's not a classic location, we have to be very careful. And that's where CT may become very helpful. This woman was a little bit older, came in with this, we weren't quite sure, so we got the CT, and now I think you can probably see she's developed some osteoclastic changes there and a little stress fracture, oblique fracture line in that subtrochanteric femur. Obviously, especially in younger patients, we want to avoid biopsy because it will sometimes mimic an osteosarcoma pathologically. Another bone stress injury that's not really up around the hip, it's usually down along the proximal to midshaft of the femur, is called thigh splints or the adductor insertion avulsion syndrome. That's a mouthful. Now, if you'll notice the adductor longus and brevis, they pull, a strong pull on this portion of the femur, and that's where we see this, and that's why it was originally thought this is probably related to those muscles. The problem is it refers pain up to the hip and groin, and so I am convinced that there are some case reports in the literature of marathon runners who suddenly just fracture their subtrochanteric femur. And my guess is, because we've seen this in a lot of our athletes, they come in with groin pain and everybody thinks, oh, they pulled a muscle, they've got an adductor strain, we'll do a little PT and then get them back in the game. And in fact, they're developing a stress reaction down here that's referring pain up there. Well, the important thing, radiographs are often normal, the important thing is that this can be quite a ways down. And think about if you're doing a normal pelvis for hip pain and so on, we're going to probably miss some of these. There's no question we will. But in this case, I think one of my partners, this is one of the first ones we saw, noticed, and I'm not kidding, just a little tiny bit of white. I don't know why we had an extended view. I thought this was probably going to be a vessel, but it turns out that that was just the periosteal fluid related to this stress reaction. Now this one is a little bit more flagrant here. And again, these will often kind of extend up to the very edge of your field of view on a pelvis. So I will always take off the annotation so I can look down in that corner on each of the femurs, because this is a very important lesion. That's in a weight-bearing portion of the bone that can snap if it continues unabated. And you can see in this case, this is one of our athletes, how significant this is. I mean, they've got periosteal change, they've got endosteal edema there, and then they've also got some cortical changes there with thinning and a little bit of high signal, developing a stress fracture in this highly weight-bearing bone. It's important to know where the dangerous stress fractures occur, and in the hip, that's along the lateral margin, the tensile side. This is a list of those that tend not to do well around the body, but the one I want to focus on is this, because, like we were talking about in the elbow, when you weight bear, because of the shape of the femur, this is known as the tensile side because it's trying to kind of arc on that convex appearance. On the inside, it's compressive, okay? And so most stress fractures of the hip are down in this basicervical medial neck, and they do just fine because every time they take a step, it's pushing the fracture together. If you happen to see a developing lucency or stress fracture, a little sclerosis, something up here, that deserves a phone call because under tension, that can easily displace with weight bearing, and so those are the dangerous ones on the lateral side. Now, I just throw this in, you're all well aware of this, but just because it can sometimes mimic, in this case it wouldn't mimic because you'd have to have the world's largest contusions of both femoral heads, but it can mimic either a stress reaction, and sometimes we do see small insufficiency fractures up in the subchondral portion of the femoral head. But when you see this kind of diffuse edema throughout the head and neck, think transient bone marrow edema. This was, in fact, kind of a classic one. It was originally described in females. This lady had just delivered twins and developed this onset of bilateral hip pain. She came in and had the very classic findings. We brought her back a few weeks later. Her pain was getting better, and this may take up to a year to resolve, but it is a self-limited thing. So when we see this, that's kind of a don't touch lesion. Now moving on to the articular portions of pain, we've got the gadolinium arthrography. Some people now are saying that 3T without gadolinium injected into the joint is just as good. But if we look at labral tears, one nice thing is they tend to occur in the anterior superior part. Here you can see, hard to tell just on a sagittal image, but on the coronal image, you can see this meandering tear in that anterior superior part of the labrum. Paralabral cysts, like in the shoulder, are very helpful for identifying underlying labral pathology. So here we can see one along the superolateral joint. Here on an axial scan, we see it within the labrum. So when we see those on T2-weighted imaging, often if we even can't identify the labral, we're going to say that this is likely related to underlying labral pathology. This was a yoga instructor with hip pain, and she wasn't all that old, but you'll notice she's got kind of a ratty-looking labrum here. She's got tremendous loss of cartilage up here, but this just looked funny. Remember I said to always look for that ligamentum teres? If you follow hers, it's markedly thickened, very ill-defined, and it looked like she had at least a partial tear of that, and that's been well described now. They're even describing how they repair these things deep within the hip. So keep an eye on that ligamentum teres. Finally, the femoroacetabular impingement, something I'm sure you've heard a lot about, a hot topic for the last several years, both in orthopedics and in imaging. What we're talking about is here you have the normal clearance of the concave femoral neck with the acetabulum. The two types, the cam type being the asymmetric femoral head where you get this extra bump of bone which can then impinge on the acetabulum, so that's the femoral head problem. The pincer type is just what it sounds like, where you have the either overcoverage from the acetabulum or acetabular protrusio of the head, where the problem is on the acetabular side impacting on the femur. The truth is that femoral head or acetabulum, but most patients usually have features of both in some way, so that it's a little bit artificial to try and decide, is it cam type, is it pincer type, is it FAI or not? So one thing we can look for on the plain film is that kind of pistol grip deformity where you lose the concavity of the head there. That does not mean that they have femoral acetabular impingement. And what we say here is just like in the shoulder with impingement syndrome there, this morphology may predispose to femoral acetabular impingement and symptoms. Now, if we look at this on the MR arthrogram, we want to look in this axial oblique plane, and it'll look like this. And people do all kinds of angles and all that, but if you just look along the anterior kind of margin of the femoral head on the oblique plane, you can see this extra little bump right here. Then we look for the pathology. Here you can see a labral tear associated there, and then some significant cartilage loss, again, focusing on that kind of anterior superior portion of the joint. All right, we're getting there. Just to talk quickly about some tendons and avulsive injuries. Obviously, you can have all kinds of tendon pathology, but the avulsions are common in younger patients. The young athlete here, this was 15 years old, and he had an rectus femoris avulsion on this side. Came back 3 years later, and notice, look at the size of that thing. That's sometimes called a hurdler's fracture because the hamstring pulls that off. But notice also, he had a sartorius avulsion. This poor guy was like an avulsion teaching file here. But as we move along now, the sartorius, again, is going to be the anterior superior iliac spine here. As we look on MR, this was about a 16-year-old who came in with kind of hip pointer type pain out anteriorly. And here you can see on the T2 weighted image, a little bit of asymmetric edema there. And when we go to the fat sat image, hard to tell. This is a sagittal image. Here's the rectus femoris, so a noisy image. But you'll notice where the sartorius should be attaching, it's partially separating from the bone. Now the rectus femoris, here you can see one pulling off from the anterior, these all look alike, so I'm not going to spend a lot of time with them. Off the anterior inferior iliac spine, here you can see the change within the bone as well as the adjacent soft tissue. These can sometimes, if they have a tremendous amount of soft tissue reaction, mimic a tumor. And again, the plain film will often be more helpful for diagnosis. Here's the rectus femoris on the sagittal, again, pulling away from the apophysis there. Gluteus medius, this again is not usually in the younger patient, usually in the older patients. And remember, it comes in on the greater tuberosity back there. So if we look at that more closely on an axial scan, here's where it's coming in on the posterior kind of greater tuberosity. And if you look at that, you can see the high signal around it, little attenuation and ill definition of the fibers. You'll first notice the edema on the fat sat image, and in older patients, that's one classic area that I always look. Hamstrings are hamstrings. Here you can see edema within the marrow, partial tearing there. And again, we see this in both young and athletes, but we also see kind of a degenerative partial tearing, probably due to the tendinosis in older patients, which will sometimes, I remember one woman was out in the garden, felt a pop, and it was probably just like other attritional kind of tendon diseases where she finally just tore it after the degeneration. I'm going to talk more about the adductor longus in just a moment as part of the athletic pubalgia discussion. And then finally, just the snapping hip. Don't forget about this. This was a lot of high signal, but it wasn't really where we'd expect the gluteus medius, wasn't really in the trochanteric bursa. But if you look here, it goes all the way along the iliotibial band here. And when we see that kind of edema there, it's probably what's known as the external variety of snapping hip. You're probably aware the iliopsoas can snap over the anterior acetabulum with certain motions in the internal snapping hip, but this is an example of an external snapping hip. Muscle injuries are graded strain, partial tear, complete tear. The strain will just have feathery edema within the muscle. Partial tears will have some muscle disruption. So common sites are going to be muscles that cross two joints. And around the hip, you're talking about the quadriceps and the hamstrings. So here we go. This is a young woman runner at UVA, and you can see on the coronal scan something's wrong. So we'll go to a little more high res. Notice that for some reason the rectus femoris is one of the most common, much more common than any of the vastus, medialis, lateralis, and so on. So as we come down, notice the multifocal partial tearing she has. It's not just feathery edema, but you can actually see disruption of muscle fibers as well as a little bit of fluid around it, but not much. It's mainly this partial tearing at multiple sites within her rectus femoris. Now, this was a little more significant, and there are some things we can comment on that will help to determine the prognosis for some of these athletes that need to try to get back in the game. This is one of our football players who felt a pop while he was running down the field. It must have been quite an explosion, because here in his quadriceps, you can see the ischium here. You can see the feathery edema that we would normally, not quadriceps, I'm sorry, the hamstrings. The feathery edema, which would normally indicate a strain, but this is big time fluid, and you can see some fascial fluid down here, one of the things that we're looking for with a more severe injury. Here you can see complete disruption of the muscle and a hematoma that is formed with extensive fascial fluid. So I don't think I need to tell you that this is going to be a long-term kind of recovery for this football player. And again, look at the cross-sectional area. They tell me that if it's less than 50% of the area that's disrupted on a cross-sectional image, then that's bad prognosis, as is the fluid collection and fascial things. Trochanteric bursitis, very close to the gluteus medius, often occurs in the same age and sometimes occurs with gluteus medius tendon pathology. But here you can see what looks like a more discrete fluid collection out along the greater trochanter. Here it is on one cut just posterior to that. Iliopsoas has a bursa which may communicate with the hip, so you might see this on an arthrogram, but it usually runs right up here. The biggest ones I've seen have been in rheumatoid patients, where they'll go up into the pelvis along the iliopsoas. And then finally, the ischial bursa lying just posterior to the hamstring tendon there, and here you see it on a coronal scan. So this is it. The athletic pubalgia is something that is a hot topic because we don't understand it, and yet it affects a lot of athletes. Used to be called sportsman's hernia, sports hernia, Gilmore's groin, hockey groin, all kinds of stuff because nobody knew exactly what was going on. If you look at this area, it's complex anatomy. I remember hating to study the inguinal canal because of all the different things around there that I couldn't understand. But I want you to focus on one thing here that seems to be coming to the fore in terms of pathology. One thing to remember is it tends to be around the symphysis. The other thing is it tends to be related to the rectus abdominis and the adductor longus. And this is that rectus adductor fascia that I was talking to you about that crosses and attaches on the symphysis there. So you've got tremendous pull going in two different directions. It's one theory why if you don't have good core strengthening of your rectus muscle, you may become out of balance here and develop these kinds of symptoms because of that muscular imbalance. All right, but let's remember that fascia, and now we'll look at that. Now, if we look on the sagittal scan, there's the rectus muscle coming down, and this fascia loops around along the ventral surface of here and attaches more, the rectus fascia attaches on the inferior portion of the symphysis. It really does cover the anterior part, and then the adductor longus takes its origin and kind of enmeshes, from what I understand, with that. And so here you can see at the level of the symphysis this thick kind of rectus, as the rectus comes in, and the adductor longus is going to be taking off there, and we'll see that better in a moment. Here you see it in a pure axial scan. This was, by the way, one of those angled axial scans to look at that. Here you can see on a pure axial scan the symphysis and then that fascia coming along the anterior margin of it. Now, athletic pubalgia is a differential diagnosis, and that's why I think I did ultrasounds for a long time trying to see the hernia and so on, and I think the MR is the answer because it may be coming from distant out in the hip or somewhere referring pain into the groin, so we need to look at everything. It can be hip pathology, proximal femoral stress injuries, and then this, again, kind of like chondromalacia patella, osteitis pubis, kind of a garbage basket term, but we take it to mean stress changes within the marrow of the symphysis. Here you see more unilateral edema on the right in this patient. Here you can see bilateral, a little bit more on the left, and you see fluid within the joint itself. We would probably describe this. Sometimes the residents or fellows will use osteitis pubis. I tend to be more descriptive and just say compatible with stress changes along the symphysis pubis. On our athletes, they will not infrequently ask us to inject this, again, to try and calm down the symptoms so they can get back. We usually see this twisting injuries, soccer, lacrosse. Those are the big ones that we tend to do this kind of procedure on. Now, what about the soft tissues? Here you see some change within the right symphysis and so on. Notice the fluid in the joint, but notice also this, sometimes called a cleft sign or secondary cleft sign. Here is where the adductor longus is going to be taking off, so this is probably a disruption of either that fascia there, or sometimes in a younger patient, the apophysis of the symphysis will get disrupted in that region. But look carefully in the soft tissues next to the symphysis for a disruption like this. And here's the one I showed you a moment ago. Here's the rectus abdominis coming down. We're just anterior to the symphysis, so this is part of that fascia. And here you can see the adductor longus, which should be attaching on the symphysis, is pulled off and avulsed into the proximal thigh. Just so that you know, I'm going to go quickly here because both facet joint arthrosis as well as discogenic pain coming from annular tears and disruptions will typically refer pain to the thigh and hip. Now, they'll often have low back pain as well, but sometimes they'll come in complaining of hip pain, and just realize that it can come from one of these two locations. The other thing is, when you're looking at a pelvis, remember to look here. This was an athlete who had left hip pain. Didn't see a lot in the pelvis, but noticed something going on here. And luckily, our axial body coil kind of scans got that high, and it was enough to show us the disc protrusion that was kind of slamming the left S1 nerve. SI joints, I'm not going to prolong this. This was a septic SI joint going down along the sciatic nerve, but it can mimic and cause what's considered to be hip or even radicular pain, as in this case.